to attend this webinar. Which is, as you can see, let me just get rid of this slide. It's about a project that we conducted last year. We reported the findings in September. And now we're trying to promote them more and to engage with as many people as possible in order to ensure that the findings actually are implemented. But I will talk a little bit more about that in a minute. So my name is Professor Irena Papadopoulos, and I'm the head of the Research Center for Transcultural Studies in Health, and that is the center that conducted the study. The study was funded by the Burdett Trust, and whom we like to thank for the funding. And as also to note that this meeting is being recorded. It will not be showing the audience, so don't worry about that, but you can keep your camera off if you are concerned. Because there's a lot of people who were interested in attending this webinar, but due to work or other commitments couldn't, and they have emailed us to ask for the recording so that they can watch it later. So I hope everybody is okay with that. Now, the aim of the project, as you can see there, was the identification of the components that would be used to produce a national strategy for the provision of spiritual care and support during major health disasters. I just want to emphasize the fact that, of course, spirituality and spiritual care has been used and taught and discussed in health and social care courses, and also implemented in practice to some extent. But our work has three differences. First of all, there is a cultural competence aspect to the work. Secondly, the study was done during the COVID period, and it is COVID orientated, obviously. And that links to the third point, which is major health disasters. So COVID being one of the major health disasters, but as we know, and as is predicted by all the authorities internationally, major health events are going to be happening more frequently in the future, and therefore we need to develop a strategy. In the UK, actually, we need a global strategy as well. And we decided to focus on this aim, on this aspect for our work, because the year before, in 2020, during the first peak of the pandemic, we conducted another study gathering data about spiritual care for hospitalized patients during the peak through online sources. And that project showed very clearly the need for the development of a national strategy. We have lots of little, we have guidelines and little, maybe some protocols and things, but there is no comprehensive strategy that has been developed or practiced or ready to be put into use for future major health disasters. So, so the aim really of this webinar is to, as I said, to engage, to disseminate our findings and to engage with people who are interested in this area of health and social care, and maybe who are practitioners of social spiritual care provision, and hopefully we will you will become champions of this work, because we have disseminated our findings quite widely, and we also sent a report to key people in the NHS and other organizations, and unfortunately we have not had any response, which is sad really, because we were not only do we believe that we have produced something that is useful and should be implemented, but we actually did it in record time in order to be to offer it for use in practice, for more efficient and practice about this. Anyway, so just before I move on with say a few other things, I just wanted us to reflect and to think for a moment about all those 150,000 plus people who died in hospitals or care homes, etc., from COVID. And also to remember the hundreds of thousands of people who were hospitalized, severely ill during the last 2 years. And just think about these people lying in hospital and not having access to any a relative or a loved one to to provide emotional support, to hold their hand, and so forth. A lot of the times people were by themselves and dying alone, and this was reported by all the people who have whom we have interviewed. Of course, the hospital carers and other carers, we are concentrated in the hospital context, but they did their best to provide some support, but they were overwhelmed by the whole situation, as you will hear from Runa, who is going to tell you a little bit more about the findings soon. So, and also a lot of the staff were sick themselves and all totally tired, and there were shortages of staff at the time as well. One should expect that, and of course. So that is really the background, a little bit of the background of what motivated us and what you will be hearing about in the next hour or so. So let me now move. Okay, so the agenda for this afternoon, I've done the welcome and the aims and everything. Dr. Christina Kouloglioudi will talk to you about methodology in a minute. She will be followed by Dr. Runa Lazzarina, who will speak about some of the findings, and then I will talk more a little about the components of this strategy and show you the plan that we have prepared. And then hopefully we're going to have some time for discussion and questions from you and your opinions, and we will conclude, come up with some conclusions or some suggestions for the next steps, and we aim to finish at 2 o'clock. So hopefully that is fine with you. So the reports, both the reports, we're talking about the second report here, the second study, but the first study is also reported, and both reports are on our website. And this is the link for that, where you can find the two reports. They are nice reports, and they're very easy to read, and they're very, very informative and pleasant to look at as well. So hopefully you will visit the website and you will download the reports. Something has passed from my mind. Okay, the last thing I want to say is that if you have any questions or any comments during the presentations, please leave them in the chat, and one of us is monitoring the chat, and we'll be picking up those comments and questions for later. So I think over to you, Christina. Thank you.
Thank you, Rena. I will just share my screen.
Do I have to
everyone?
Stop sharing? Mine.
Yes.
Okay.
Yes. Alfonso, how am I doing?
Yeah, perfect. We can see your slides. You just need to enter presentation mode.
Okay. All right, thank you everyone, and welcome to our presentation. I'm Christina Koulougliotti, and I join you from Worthing Hospital in the southeast of England. And as Rena said, our main focus was to explore how a spiritual care and support was provided during the first two waves of the pandemic in the NHS. We focused in the NHS because we are here in England. But we wanted to hear from people who had the experience, and from there to hear from them themselves and share their views. So we conducted a descriptive qualitative study. We used semi-structured interviews. And of course, we used a purposeful sampling method, and we were after leaders in the NHS, nurse leaders and chaplains, but also spiritual leaders of religious and non-religious organizations in England who had provided support, spiritual care and support during the pandemic. And we wanted to hear their views. We wanted to hear from people who were in the position to reflect and provide an opinion of how spiritual care and support was affected, and how they actually dealt with the challenges of the pandemic when it came to their staff, their patients, families, and themselves. We received
Sorry, your slides are not moving if you change them.
Can you see study design? And
you're not in presentation mode, I don't think.
Oh, can you only see my first slide then?
Yes, on it. I cannot see your first slide.
Oh, how about now?
Yes, it has moved.
Okay, is it study design and sample now?
Yes.
Okay, so I'm sorry everyone, I just talked about that slide. So I will move on to the next one now. Regarding the ethical considerations of the project. The project received ethical approval from Middlesex University, and in order to approach the participants, we used a gatekeeper approach. We had a list of organizations.
Very sorry, Christina, but actually your slides are stuck on study and sample design.
My God, why is it happening?
That's it. Keep it to the.
Is it now? Are we
presentation mode? I think you should keep the presentation mode. You should be okay.
Can we see now ethical considerations?
Yes.
Okay, all right. So we used the gatekeeper approach, where we had a list of organizations that we wanted to approach. We approached the organizations, and after receiving approval from the gatekeepers, we were able to cascade our invitation. And we asked them, and then those who were interested and wanted to participate, they approached directly. They approached us directly, they sent us a message, then we were able to give them the participant information document and informed consent, and also at a later point ask any of their questions and ensure eligibility for the study, and later on schedule an appointment for the semi-structured interviews. The interviews were all conducted virtually after receiving informed consent. In total, we were able to interview 25 participants. We had 9 senior nurses who participated from England. 4 of them were working in a critical care setting or an end-of-life setting in the NHS. And we also had 16 chaplains who participated, and spiritual leaders. So I should have said here, there were not only chaplains, there were also spiritual leaders. 9 of them, they were in senior roles in the NHS. The majority of our sample had a lot of years of experience, more than 16 years of experience. And we had 14 female, 11 male participants. The mean age was 50 years and above of our participants, and the geographical areas who were actually were able to include at the end was the London area, the south of England, east and west, and the north of England, the Midlands, and we had a participant from Isle of Man, which, even though it doesn't consider officially in England, we thought that it would be interesting to include, since they were willing to share their views. All the interviews, as we said, were conducted in either using Zoom or Microsoft Teams, and they were conducted during May and to July, from May to July in 2021. They lasted about 35 minutes to more than an hour, and they were conducted by 2 members of our research team, following an interview guide, which had questions specific to their experience of providing spiritual care during the pandemic, the first 2 waves of pandemic. We also asked our participants to reflect on any changes that happened during the first year of the pandemic. And then we asked them specific questions related with the national strategy, their views, whether or not we have to have one, and how it might look if we had one. The other thing that we asked our participants was to, beyond the interviews, we asked them to share documents, to share any policy documents or guideline or resources that they had from their organizations that we could actually review to see what is the state of the play, as we say. 18 participants were able to share with us documents. In the meantime, the interviews were being transcribed, they recorded and transcribed, and soon after the interviews, the transcriptions were anonymized and the team started analyzing the data. We analyzed the data we had 2 levels of analysis. One was focused on the documents, and beyond the documents that the participants shared, we also have done a literature review of ourselves to online sources to see what is out there. And we were looking for examples of good practice, for the latest innovation, for approaches that other people have used, that they have been effective in the past, and also in a good presentation mode that we could potentially use as a part of our recommendation. At the same time, the research team was focusing on the interviews. The analysis was happening along with the interviews, and the team had intense meetings, regular meetings, weekly meetings, where we were discussing what we were reading through the interviews and the transcripts, along with how the interviews were going. We use a naturalistic approach, and we were looking for elements related with the experiences that we were hearing, but also changes in practice and future recommendations. I will now thank you all very much for listening, and we can move on to Runa, where she's gonna share with us the findings of the study.
Thank you, Christina. Can you all see the?
Yes,
Yes.
your front.
Yeah, all right. Okay. So, 1 second, sorry. I don't, there's something wrong. 1 second, sorry, apologies. All right. Okay. Yes. All right. Can you see the first slide in relation to the findings, everyone? And can you hear me well?
Yep, all perfect.
Thank you. Thank you very much. So welcome again, everybody, from me. And this is Runa Lazzarino. I have been involved in both the studies in relation to spiritual care during COVID in England. And today, as what Rena and Christina have said already, we are discussing the second study, which was based on qualitative interviews with senior nurses and chaplains in England. And I am going to go over the findings with you now. And my slide should move. Yeah. Okay. So what I am presenting in these few minutes ahead is actually part of the findings of these studies, because Rena will then talk more in detail about some of the themes that are feeding into the components of the national strategy that we are proposing, stemming from this research. The study participants, as said, were nursing, senior nursing and chaplaincy staff. Because as we know, especially during the emergency times, but also during the pandemic, they were frontline workers who bear the most part of the spiritual care and support to dying patients, their relatives, and their colleagues within the NHS and also outside. Their experience can provide evidence which is needed to help us understand what has happened, which is something unprecedented, as we know, and to try and be more prepared in the future in a more efficient and culturally competent way. So, as I've already said, these experiences are then in our study, as Rena will show later, are more in detail articulated towards the identification of a far longer series of components for the national strategies, So here we have encapsulated the experiences of our participants into 5 big themes, and the first one is in relation to the novelty of the experience that our participants have reported. Of course, nobody has ever experienced anything like this before, and it was a unique and tremendously massive health disaster, which some of our interviewees called apocalyptic. They compare it to war zone. And some of them, they even describe it as pure hell. So, of course, these the tremendous and the tremendous novelty of these events provoke exhaustion and fear and a great deal of anxiety in our participants, as well as probably across the whole workforce in the NHS. The other big theme that can highlight the one aspect of the experiences of the participants is about unpreparedness. So all the participants in this study declared that the pandemic caught the NHS and the government unprepared. So the majority declared that their employer had some policies or strategies for major incidents, but these very rarely, if not nothing at all, they included information and guidelines for the provision of spiritual care. Other participants declared that they were not aware of the existence of any relevant strategies at all. And in addition to this unpreparedness, there was also there were also issues in relation to communication, as Reina will talk about later. So the government unpreparedness was also evident in continuous shifting of guidelines and information and instructions given in relation to, for example, policies for visitors, which has been a very, very prominent and important topic in our study, as well as in relation to PPE resources and treatments and so on. So in addition to these, of course, there were numerous issues regarding workforce. And for example, there were, of course, sudden reduction of staff due to positive COVID tests or due to shielding or due to resignation as well. And this also was not prepared enough and dealt with adequately by the Public Health England and NHS England as well. The third theme that encapsulates the experiences of our participants is, sorry, I think. Okay, sorry, that was this one first. So is a sense of being totally overwhelmed by the number of deaths. So the number of deaths, as we all know, was unprecedented, and we should never forget about this. And several participants expressed that they themselves and their staff felt professionally and emotionally drained. And a number of chaplains and also nurses found that as a shocking phenomenon, especially thinking about that many patients were dying without their relatives around. So some of our participants talked about an injustice of dying alone, and other expressed more figuratively the silence, the unusual silence in the hospital, and other described this isolated journey that many patients and relatives were facing toward their end. So the notion of moral injury was raised by several participants, and it was also accompanied by a reflection on the need for long-term support for staff and the public too. So we talked about the need for being ready for a collective long-term bereavement and remembrance. And then there were also some, if you want, positive reactions. I think we can think of them as expression of resilience and adaptation. So the first three themes are very negative, whereas these last two are more lessons that we need to treasure for the future. The first one is the multidisciplinary working. So our participants declared that the pandemic and the situation they find themselves in without guidance and in such tragic situation ignited two things. One is multidisciplinary working, and the other one is the use of technology that I'll talk about later. So multidisciplinary working is intended both within the NHS at all levels. Within chaplaincy team, ICUs team, the well-being team, but also portering and cleaning staff, everybody. So a very democratic and strong sense that everybody should be cooperating. Especially chaplains, several chaplains mentioned that during the pandemic they developed close relationship with other teams that they never had before. So this, the pandemic has contributed to change a little bit the profile of the chaplain's role within several trusts. It also became obvious that staff were in need of more support, and so there was a deeper appreciation of each other's roles and to work together, and therefore we have witnessed several good practices to support staff stemming also out of these new collaborations within the trust. For example, new places of contemplations, even outside places, well-being hubs, and so on. But also there were new and stronger collaborations external to the trust with religious and non-religious communities and relatives to better support patients. And as I mentioned, technology. So there was a general agreement in that technology enabled to do things that were never done before. And of course, on the one hand, this is positive, and chaplains as well as frontline nurses and other members and other members of staff within the NHS could use several technological devices from smartphone, tablets, and so on to keep their communication going in the face of the social distancing and the measures to prevent the spreading of the virus. And so several chaplains reported they could organize teams and training and be in contact with families, and also if working from home. However, on the other end, there was also a consensus that physical presence is ultimately irreplaceable, and technology is a second best choice within these circumstances. So this is it from me, and now I will pass it on to Reina, who, as I have anticipated, will cover the second part of the results of this study, where we have pulled out more specific themes that are directly feeding into the components of the national strategy that we have outlined and drafted thanks to this study. Thank you to all participants again. Some of them are around, which is a pleasure to see, and thank you.
Thank you, Runa. I shall try I shall try to find my presentation again. Oh, share screen. Okay. Oh, what happened? Right. So the key top issues and from both from methodological perspective and past experiences have been covered. As I said, you can have the full description and lots of different quotations, the voices of our participants. And again, we want to thank all of those people who allowed us to interview them and to contribute, enthusiastically and with a lot of commitment to this project. Their voices are really quite loud on our report. So why did we actually choose to go down this road about identifying the components for a strategy? I mentioned the first study that we did in the year 2020. And from that study, we came to the conclusion that there was a lack of strategy for the provision of spiritual support and care during major health disasters. As you can see there, the findings from that study illustrated that there was very little or the spiritual care that was given to these masses of people who were now hospitalized in quite serious conditions, health was reduced because of the resources, because of all the rules that existed that did not allow people to visit, and the volunteer spiritual caregivers to come in. This was reduced, and most of the care that was given was at a distance, and it was as Runa just mentioned, used a lot of new technology, for example, iPads and iPhones and so forth. So that was our motivation. We discovered very clearly that there was lack of preparedness and there was no strategy. So we just decided to go for the next study to do to look at those components. So I will show you now the components, but just a few words about the framework that we adopted in order to devise this plan and present the masses of data that we had collected in a way that is very summarized, very condensed, and is a plan that can be taken away and people can start working on it. So the first thing that we thought the three pillars is preparation. So who is going to prepare the things, the components that we have discovered and had been recommended in terms of, for example, protocols, training, resources, all of these things have been mentioned. Who was going to be preparing? How were they going to be prepared? Who was going to deliver? Who was going to coordinate the delivery of the training, for example, or the protocols and so forth? And evaluation is always very important for anything, any new policies, any new trainings, any new everything, because we need to know, learn whether that was useful, whether it was accessible, whether it was, it brought about, it had impact and so forth, and whether what we were doing was, providing for, outputs of quality and equality as well. So that was the simple framework. Now, is there a way to reduce that? Okay. So the all the data that we collected, we put them on this visual diagram, again, for as a summary and as an easy way of looking at, you know, the key things, the priorities, and so forth. So you can see we have 4 C's and 4 T's, and we also have an ear. So if we look at the green bit of it, the first thing really it was the recommendation was that we must learn from the past. We must be aware about what happened in the past. And the past really, for the purposes of our project, was the year 2020 and the first wave and the first peak of the COVID. And we need, you know, and this is what we have done. We collected stories and good practices and the kind of actions that people were saying we need to be proactive and to be prepared. And so they're all included in our report. I will leave the equality and resources and then go to the other themes. So the key themes really of that we identified from all the data that we collected was the 4 C's, community. So for example, you know, the culture that we were operating in, you know, whether it was hospital communities or actual communities with their own cultures, empowering the community, engaging with the community, very important issues that are all expanded in the report. The other C was collaborations. And again, Runa mentioned that how collaborations between the multidisciplinary teams and everybody who was working within the hospital and to some extent a community providing the spiritual support, how they were able to connect with all the people in, you know, all the other teams and all the other people who were working with these very sick people, and to contribute and to participate in the discussions. So and be part of the resources. Communication, of course, underpins everything. But in this case, we talk about the communication that one of the issues that we identified was that the public and the healthcare frontline staff and management were losing their confidence because of all the complex and messages that they were getting from the government, and which was very frequent and very often the messages were contradictory. So, you know, that needs attention in order to keep the confidence of the public and the confidence of the staff. Communicating with very ill patients, wearing masks and a total PPE was very difficult for the staff. And they mentioned how often they couldn't be heard, and because of all the noises as well of the machines are in the environment. But they said at least we can show a smile, and the only thing that they could think that they had hoped that the patients could see them smiling was through their eyes. Our care and spiritual support, of course, this was discussed, and the way that it was done and the importance of it in terms of the staff, the patients, their relatives, vulnerable groups, and the importance of debriefing were also included in the interviews. If we go to the T's now, one important element was training. And there were lots of components connected to training. And I will maybe expand a little bit more when I show you the plan that we have prepared. Now, terminology, it was an interesting finding because there were even people who, some people we interviewed, they would say, what do you mean by spirituality? How do you understand spirituality? Also, so that was challenged. And there are, of course, there is not one definition of spirituality. It is a very, very complex and multicultural and multi-everything notion that probably does not lend itself to one single definition. The same with spiritual care. But chaplains themselves were actually reflecting on the definition of their role and the definition of chapel. And, you know, is that a place just for religious reasons as the people and the public identifies with, or should that be a bigger space for, you know, emotional, spiritual wellness and so forth. Technology was mentioned a lot because and the variety of uses were kind of like included in the discussions we had with the interviewees, but also some of the problems that they had in terms of, you know, not everybody had a good internet connection. You know, not everybody's device, they did not have enough devices to use and so forth. So there were problems, and some people were not technologically savvy, and they tried to help each other and to teach each other how to use the technology. But obviously there is some room for the future for preparing people to use technology in not just for the major health disasters, but technology is being embedded faster than we probably would have anticipated in the health and social care domains, because maybe of COVID. That's one of the side effects, I think. Trust, that links again to the issue of the public confidence and issues, the negative aspects of technology that we were made aware of. One of the another major thing really, and we know that a lot of people who had died were from the Black and ethnic minority groups, including nurses and doctors. And there was an issue in terms of the equality about in the usage of technology, in terms of allowing the occasional visitor to go inside the hospital to visit. There were some places that allowed that, and the majority of places didn't, and that was not considered good practice. So that needs to be thought through, I think. So the fair visiting policy and access to family needs to be really considered very seriously, because a lot of people didn't understand why there was such a strict policy. And of course the resources, having the enough people working, having the spaces and the places to for people to contemplate whether there were friends or family who came into the hospital couldn't go into in the wards, but they stayed in outside and maybe went to the chapel. The the provision of safe PPE and without any that was enough and available all the time. And the care for the dead, people said they ran out of black bags to put, the body bags to put the dead bodies, which sometimes they were in piled in corridors or in rooms. Some distressing stuff, I think. Now, so how does this plan look like? So this is how the table looks like. So we have the theme on the one side. So then we have the components related to that theme. Then we have recommended the responsibility for the development and the preparation that is needed for that component to be enacted, the delivery of it, and of course the evaluation. We would be very pleased to hear from you, those of you who have got a copy of the report, or those of you who are going to download or read the report online, to tell us in particular your views about the preparation, development, delivery, and evaluation, whether what we have recommended is appropriate and whether we've missed some kind of key body or group of people or method or something like that. So we are very happy to hear from you and to adjust the plans. There are lots of components that we have identified and we have included in this plan, but I'm not going to go through all of them because we don't have so much time. I will try and do as many as possible. So we talked about, to begin with, terminology and, a definition for spirituality, and we actually came up with a definition that encompasses a lot of the recommendations and the definitions that people use during their interviews. So we put something together and it is in the report, and we do recommend this as a useful definition to be taken on board. So I'm going to read it out. Spirituality is an integral part of all human beings, which is connected to religion, faiths, personal philosophies, a relationship with ourselves and others, the environment, and a transcendent superior force, which helps us understand the meaning and purpose of our existence and that of others. Now, of course, I think the healthcare, health and social care providers do not deny the importance of spirituality. In fact, spirituality was included in the first document that came up in 1948 when the NHS system was launched, and it said in that document, all people, be they religious or not, have the opportunity to access pastoral, spiritual, or religious support when they need it. So it's kind of like in the Constitution that we, just because we are very busy, we having an emergency, we have a major disaster, um, spirituality and spiritual care is part of the whole care we should be given. We care for the body, we care for the mind, we have to care for the spirit as well. And it's not an optional extra. It has to be really, we have to find better ways of integrating it in every occasion, particularly if, well, yeah. Anyway, so you can see there that we said, oh, what am I doing now? Okay. So we have definitions about spiritual care there. We made a definition about chaplains and chaplaincies. We talk about that. And most of the chaplains that we interviewed are supporting and implementing and putting into place a kind of multi-faith, but not just faith or spiritual kind of places, and to avoid this notion of chaplains are religious. So let's go to the next one. So we have community here as another theme, and you can see there the various components that we have identified and how we recommend that they be implemented. But as we Runa, I think, mentioned as well, and then probably I mentioned a couple of times too, that we have to have a plan and how to execute the provision of spiritual care and support in major health disasters. And not just to have the plan, but just like all the other plans that the NHS, for example, has for major disasters, not major health disasters, major disasters, they experience, they have events to practice and to implement the plan so that everybody is well prepared when in a real situation, how to execute their roles and what to do and so forth. So we think that this is, it should be included and it should also be practiced. Then collaboration was a big one. I think we've talked about that, and Runa talked about it, how now there is more exchange within the teams, and there is better working conditions, and people, there is a respect for everybody's role, because during COVID, everybody's role was seen important. So communication, I talked about the masks, and we obviously need to rethink about and identify better designs for masks, because when you have a situation like COVID, you have to wear a mask, but there must be ways of making those masks less of a barrier to communication. Okay, there's more issues there about communication. All the green lines are about communication. We've talked about trust, gaining and keeping the trust of staff and the public, and having good protocols for that. I think we've covered care and support. So I want to talk about training now, because I think training was one of the major issues and that people identified. They talked about the need for awareness and understanding of all the meanings of spirituality, spiritual care, the other things we talked about in terms of terminology. And of course, training for in spirituality currently does include information about major faiths and major and minority faiths as well. But we mustn't neglect that if we're in the plan for the specific training that we should be doing for major health disasters. So we need to develop more tools for assessing spirituality. A lot of the people mentioned that they don't know, they don't speak about spirituality. There are misconceptions about approaching a patient and asking them about, their religion and their spirituality. And we need to have an assessment tools that are agreed and validated and easy to use. There is a lot more on training. Obviously, as I mentioned earlier, we need to become more culturally competent when we're talking about spirituality, and so that we will be more appropriate and more acceptable by those that we care for. It was recommended that we develop a repository of stories and good practices in terms of spiritual care in training. The training should address equality, diversity, and inclusion issues. It should also include some information about moral injury and ethical decision making, because again, we've found out, it was reported that nurses for the first time were signing death certificates, and they were part of the decisions about making who is going to go on a respirator, for example, and who is not going to be given a respirator when the respirators were in short supply. And that is something that people refer to as moral injury. As we know, that comes, other terms can be used as well. So in the training, it was recommended that the use of technology is covered, and also tools to make should be made available of how to care for ourselves and how to support others, and empowerment of nurses and other health professionals to safely and sensitively have spiritual conversations with patients, as mentioned earlier. And the use, and we mustn't forget that chaplains, and this is what some of them have reported to us, they are experts in death. And they, whereas the nurses and the doctors are not so frequently dealing with death. Of course, they deal with very sick people, but some input on this by the chaplains would be very, very useful. Technology is another issue that we talked about, and obviously we need more research and development in this on this topic. We, in terms of the equality and diversity, I just read the one on how to make PPE and other infection control resources and equipment available to all NHS trusts, and this should be inclusive and culturally sensitive. We had stories that people who had beards because of religious reasons, health professionals who had beards and other apparel where had problems in terms of obtaining adequate and safe PPE. That really is unacceptable and should be addressed. It's not a minor thing. You know, it was not mentioned many times in our interviews, but it was mentioned. And if it affects one health professional, that is an issue to be looked at. In terms of resources, again, there's loads of common recommendations there. I just read the one on about putting in place efficient systems to rapidly deal with a sudden reduction of the workforce. This was it was mentioned many times, the fact that staff were really scared, especially those who had families, how to deal with going to work and coming home, or maybe being away from their families. Some of them became either ill with COVID or ill with exhaustion, and therefore that reduces the number of people. And as we know, we have huge shortages of nurses in particular, and doctors, I think, in the NHS, and they're not out there. You can replace them easily. We have to have a proper system for replacing workforce in this kind of situations. And I think that is, I don't want to bore you, but it is not because the topics are boring, because maybe I am boring, but I hope that you will, as I said, take the report, read the report, and send us some comments. And now I think it is time to engage with you and to listen to you and hear your comments. And let's start the discussion. Thank you. Over to you, Christina and Runa.
Thank you, Rena. I see there are a couple of comments in the discussion related with the participation of the CQC, which is the quality commission here in England, for those who are joining us from abroad. And I completely agree. I think that that's a very, very good point. And a lot of our leaders actually mentioned that it's important, especially if the CQC takes the lead on it, and if it is an area where the CQC also is looking for evidence that if it is actually happening in the organizations. Now, regarding the comment about post-death care, and if that came up, because definitely impacted the communities in a different way, I think maybe Runa can comment on that, if that came up as an issue, or if it was brought up from our participants, the issue of post-death care.
Yes, actually, we didn't really focus on that, as the focus of the project was on spiritual care within the NHS, and that was lying a little bit beyond the trust's remit in relation to patients. But of course, we talked about it with our participants, and several raised how stressful it was to carry out funerals or other death rituals within the different religious and non-religious affiliations. And this was particularly harsh for relatives, as it is understandable, to be able to religiously appropriately bereave their deaf relatives and be able to give them the right rituals as requested by their beliefs. So yes, we covered that, and several chaplains, in this case, of course, not the nurses, talked about how they were able, after the initial confusion and chaos, as things progressed, they were able to deliver death rituals online, for example. And as things eased out, they were also able to arrange, according to the change in regulations, some face-to-face funerals as well. Yes, we talked about it actually in one of our upcoming publications, where we consider a little bit more philosophical and existential issues, also post-mortem care.
Yes, I agree with Runa. We did have quite a lot of information, and people did mention it a lot, as we also had information about community activities and how groups supported one another, how there were, the chaplains started empowering classes or discussions, and maybe they started a newsletter or something to share information and to support one another. So we had a lot of that as well. But because it was our remit was the hospital kind of context, if you read the report, there are some mentions about those issues, but we haven't really picked them up to put them into the strategy, because I think maybe we need a supplementary strategy. There are lots of issues in terms of they come under communication, community, empowerment. They come under those things, but they're not really spelled out. And we should be spelling them out. We have discussed them, and we know maybe we will do a supplementary kind of a list or something, because it's nice to have it and to to acknowledge that these issues exist beyond the hospital walls.
We have a raised hand from Mariano from London.
You are muted, Mariano. Unmute you, Michelle.
Hi, Mariano from the Buddhist Society, Buddhist chaplain. I have been volunteering in the NHS for a number of years, and our experience has been that we've been locked out basically from hospitals and only allowed in very occasionally, thanks to the good heart of some lead chaplains. Now, that raises some issues that I think could have been dealt with more in depth. There is systemic discrimination in the way chaplaincy is set up in the NHS. A Buddhist would never dream of becoming a full-time chaplain as a Buddhist in the NHS, because we are just 0.4% of the population. But that results in us being denied access to our own faith community. And it needs to be said that the narratives around end of life and so on can be radically different, and the practices as well. So the kind of support that should be made available cannot be delivered by other chaplains. The solution as we see it is that we rebrand, not just a rebrand, actually redefine the role of the current chaplaincy, so that you have got a professionally trained spiritual team, spiritual care team from any denomination, never mind the denomination, inclusive, yes, and giving people a chance to have a career there based on their qualifications and suitability and not their religious background or lack of. There is stronger resistance to that, vested interests, seen it myself. And so there is a need for radical solutions. There is a need to define religious support as well, because the two need to be separate. Yeah, I am all in favor of spiritual care teams made up of professionals properly trained, and theology shouldn't be a prerequisite for that. Yeah, but there is also a need for voluntary services provided by the faith communities on request. So minimal training for external visitors from the faith communities. I'm sure, some protocols can be defined and some minimal training as well, because the only thing needed is how to wash your hands, what not to do, or what you can do in there. And then, they are called in on request. Yeah. And that would sort out the problem. And that is what we are pushing for.
Just a quick response to that. We actually had a Buddhist in our sample, and the issues that you have mentioned have actually, we have heard those issues from others. There is a little bit more coverage in a kind of a general way in the report about those issues, because even the Catholic chaplain would support having a spiritual team. We were told that the volunteers disappeared overnight because they were not allowed to come into the hospital to help, and therefore the very small teams, in some places there was only one chaplain that was employed by the NHS. They are not employed properly. They're not given the professional status which they deserve, and obviously the salary. But so all of those things have actually come up, and thank you for bringing them up again. We'll have a recorded version of it. But
yeah, there is something else, because the NHS is reviewing the guidelines for chaplaincy, the 2015 ones. And guess what? There is no Buddhist in the committee, actually. Well, that is the kind of discrimination we are facing. It is not just Buddhists, it is Dharmic faith in general. Yeah, it is set up in such a way that it works against us. Yeah.
Well, thank you for bringing those things up. I mean, we're not going to stop here, of course, with our exploration of these issues, and we're looking for funding to do other things as well. And these are, very key and very important. And there are things that have been boiling for many, many years, but have been exposed so radically because of the COVID. You can now you couldn't talk about some things before because they would have been taboo, and people would have said, oh, what are you complaining about this or whatever. But now it is so obvious, and the importance of spiritual care is become so obvious, and the issues about, do you have to have, Buddhist to provide spiritual support to somebody who is not a Buddhist, I mean, a lot of other things that are now coming to the surface, and we need to address them. Thank you. I think Abdullah has his
yes.
hand up. Sorry.
Yes. Yeah.
You're muted.
I've asked you to unmute yourself, so you should be able to do
yes, it. I've just done that. Thank you very much. Again, can you hear me now?
Yes, thank you.
First of all, thank you for the whole team, but that's been an incredible insight. And just a reminder, I'd echo everything Mariano has said, but I think what's really interesting for me is leading a very large team, one of the largest teams in modern healthcare chaplaincy history at Manchester. So my question really is around how is there formulation of the strategy that goes. So my thinking is, okay, so you have Gold Command at the top of a trust or Gold Command in the city, in the council. So when it comes to major incidences, you know, you've got a kind of, okay, these are your 4 pillars or the things you've talked about. Well, is there essentially a document or a piece of or an app that says these are the things that we need to be looking at, so that there's a national kind of form, if you like. I don't want to use the word form because people get put off by forms because we fill so many forms up in trust, and I think where is the conversation with the World Health Organization, because this is not a UK problem. In my past history, I was in war-stricken countries providing spiritual care with United Nations and the military doing other work. And I think there is some collaborative work there with the defense forces to learn from their experiences. And I don't know if that's the remit. Maybe another piece of work could stem from this, is to say, what does the defense forces, especially peace convoys that go out, what do they do in terms of spiritual care? And I know what they do from my own experiences, but maybe we can learn from that internationally. And I think this is, UK is unique because it's a state provision of healthcare. So there's state ownership. Not all countries have that. Some countries in Europe do have that. So then how do we have something which people all over the world, because this is not just a UK problem, it's a global pandemic, how can we learn from our own situation, say, okay, these are the 4 things or 5 things or 8 things that we need to put in place. And if we see and the second point, I think I'm raising the question is, spiritual care is not an add-on, it's not peripheral. So when we talk about holistic care or person or patient-centered care, we acknowledge that spiritual care is important, but actually it's not core business. So how do we start looking at changing the language so that every part of the service, when they're trained or coming to the organization, spiritual care is just as relevant as asking your name?
Yeah,
Now,
and that's why I'm emphasizing the training so much, because that, I think that is, it should be starting from that point. But you know, I'm so pleased that so many people have attended. I think we had some technical problems, and maybe some of them didn't. But the issue, you say that it is a global. We also acknowledge that it is a global issue. We want to engage with the NHS. I have written to chief nurses and chief directors of this and that and whatever. I had a long list, and I send them the report. And I have tweeted. We have done a lot of dissemination activities, and nobody has even written to us to say thank you very much or whatever. So there is silence, and this is why I hope that you're going to champion this, because we have started something. I'm not saying it's perfect. I'm not saying this is what, and your questions, Abdullah, is very relevant. How do we then operationalize it? Those are lists of things that need to be done and suggestions of who should be doing it. But there are another 10 steps maybe before we can come to having the product, and why not have an app? Why not use technology? Because this is the 21st century, and we are using technology in all sorts of ways, and I'm all for that. So, you know, I don't know if some of you want to, who may have some links to those levels, can help to bring that this work in their attention. We don't say we want to do it. We are just saying, please, we've done this, take it, do what you want. I mean, if you want our input, we are very happy to give it. But it would be really a shame if, because of all the people we interview, of all the commitment, of all the work that we have done, you know, to produce what we have produced. So I hope you're going to be champions, and you're going to maybe email us and say, find a way to make this impact. So I think it's Brunton, isn't it? Who is, how do you pronounce it? Oh, hi, is it Brun? You're muted.
I just unmuted. Hello. Can you hear me now? Hi. I'm a lead nurse in Blackpool, which is the north of England. I can see some of my colleagues are on here today. So I'm lead nurse for end of life and bereavement care. And as my colleague has just said, the experiences that we've had, the way that we've worked together, and the way that we do need to learn from the things that we've experienced, we do need to take this forward. To continue to support us. I absolutely agree that we've learnt a lot through colleagues through the military, and we likewise have been asking questions about how they work to sustain their resilience in recovery, in peacetime. So there's some of the discussions that we're having in our own organisations, but I was just going to pop a line on there to say that I will feed in, we've got copies afterwards, I will feed into the lead nurse for end of life care at NHS England, and just forward this, having participated today and engaged some conversation.
Thank you so much. I mean, the military are the kings of, the masters of the notion of moral injury. You know, they've been talking about it for years. It is much more new to our world, but yes, absolutely. Thank you for your contribution, and I look forward to hearing from you. So Akhtar.
Hello, yes, thank you for a very informational session and a great research that you have started, as you said. But I was just going to say that the conversation about team approach to care, and especially an interdisciplinary team approach to care. I have worked with my colleagues about cancer care and in other issues too, but especially we incorporated the role of clergy in that one, and also spiritual care in healthcare setting, and how we need to incorporate that piece of spiritual care, and our colleagues in this area actually in our interdisciplinary healthcare team. So it's so it seems to us, no matter of this COVID, we need to incorporate the role of chaplains and other spiritual leaders or people into the healthcare system, and we need to have a global approach on that. That's my, so it seems not for COVID or cancer, we need to have a global initiative to do that. You know, that's part of the self, yes?
Yes, absolutely. The more emphasis should be given to spirituality, really, whether it is for COVID or not. But it is worse when it comes to major emergency. Obviously, the priorities and the focus is somewhere else. And there is room for this to be part, because it is part of us, and we should insist. Thank you, Akhtar.
You're welcome. Thanks.
Any other questions or comments? Well, it's gone 2:05. So thank you to all who stayed with us until now. I think listening to the discussion that we've had, it seems like the work that we have done is helpful, and there is a lot of agreement that what we have done should be, some of the ideas and some of the suggestions and recommendations we're making should be taken on board. and be implemented. We've heard about the work that needs to be done in terms of inequalities in either receiving or giving spiritual care. That is very a very, very important issue, and someone needs to not only someone, we should all be involved in kind of and providing our support to those issues. Connecting with the military, that is those of you who can, I think that would be excellent, because we did have the information we've received. We had some information and suggestions, and they are trained for emergencies and extreme events. So that would be probably very useful to do. And we need to expand and promote these issues beyond our own country, make it global, connect with the WHO or whatever, or body that deals with those things. There are a lot of reports and guidelines, but as I said, none of them connect the three things that we are interested in. And I think the three things that are missing: the emergencies, the major health disasters, and the cultural competence aspect, and all the different components that some of them are very unique, and I have not come across them in all the readings that I have made in this area. So without wishing to detain you longer, I want to thank you all very much for your contributions. Please contact us and do obtain the report. I am 100% sure that you will enjoy reading it and that you will share it with others. So thank you. Thank you to my colleagues who have presented the work. And obviously, again, to the Burdett Trust for Nursing, who have provided a small grant for this project. And all I need to say is have a lovely rest of the day and a fabulous weekend. So keep positive. Thank you. Bye.
Thank you.
Thank you very much.
Thank you.
Thank you.